Good afternoon and welcome to our Oak Bend Medical Center Happy Hour podcast. My name is Donna and I am your host. I'm very excited to welcome back our guest today, Dr. Jenna Lubrano, who will be discussing gallbladders with us. A native Houstonian who obtained her medical degree from the University of Texas at Houston and completed her general surgery residency training at Biliary College of Medicine, located in the Texas Medical Center in Houston. A very talented physician who cares deeply for her patients. Welcome, Dr. Lubrano.
Thank you so much for having me back.
Well, we're glad to have you. I don't know what it is about May, but you hear all about gallbladders.
Yes.
So what is a gallbladder and what's its function?
Sure. So a gallbladder, everybody has one, or at least is born with one. But a gallbladder is just a small hollow organ. It lives right under your liver in the right upper quadrant of your abdomen. And its function is really, the liver creates and secretes bile, and this bile gets secreted into the small intestine in order to aid digestion of fats. But some of the excess bile that's created gets diverted and stored into the gallbladder for later use. So when you eat something fatty or you eat a meal, the gallbladder, not only will the liver, release the bile, the gallbladder will also secrete that little extra bile that was stored from earlier to help just aid in a little bit more digestion. You don't necessarily need a gallbladder. The liver does produce enough bile throughout the day to support your digestion of fats. It's just a place where some extra bile is stored and concentrated.
So how would I know if my gallbladder was operating correctly?
Yeah. So the way it starts, so basically, just to go into a little bit more details about the issues with gallbladders. So some people will develop stones in their gallbladder, and stones are simply just a buildup of cholesterol, which is one of the components that is in bile or bile salts. So that cholesterol just builds up and creates stones. For some reason, some people are more predisposed to developing gallstones than others. And it's not necessarily something they've done or eaten or anything that is making it, because I've seen, all different kinds of diets in people that still develop these stones. But we do see that it tends to run in families. And a really common demographic is women of fertile age, usually in their 30s and 40s. But again, I've seen, patients in their teens all the way up to patients in their 90s, both male and female, all races, who can develop them. So in most cases, or in many cases, patients don't necessarily have any issues, even if they do have stones. So just because you have stones in your gallbladder, that does not necessarily mean that you need your gallbladder out. I may be sitting here with stones and don't even know it. So just having them is not necessarily an indication for removal. But in the situation where the gallstones start causing problems or giving symptoms, that's when a patient should come get the workup in order to get them to a point where they need to get surgery. So one of the most common presentations that I get of gallstones is what's called biliary colic. This is basically whenever you eat something fatty, you eat typically a fatty meal, but actually it sometimes will happen with even a low-fat meal, but mostly with a fatty meal. Your gallbladder will squeeze. It gets triggered to squeeze out that extra bile. And if there's a stone in there, it can get stuck right at the neck of the gallbladder. So this causes a temporary pain in the right upper quadrant of the abdomen. Some patients will feel this pain up in the epigastrium, or meaning upper middle stomach or abdomen. Sometimes it'll wrap around to their back. Sometimes it'll go across their upper belly, to even sometimes feel around the left side, or even pain that goes up to the right shoulder. But most commonly, it's in the right upper quadrant. The pain is temporary, and then it can last anywhere from minutes to hours, sometimes associated with nausea and vomiting. And then the gallbladder starts to relax, and the stone falls back out of the neck of the gallbladder, and the pain goes away. This can happen, a couple times per year, all the way up to multiple times a day. Okay, so in this case, a patient will usually see me in the office, or they'll get workup by their primary care doctor. You'll get an ultrasound and they'll see stones after you've complained about these symptoms. Okay. And that's when I would recommend an operation and do your operation as an outpatient.
Can this be serious?
So it can. So there is another situation where gallstones can cause problems, which is more urgent than what I just described, biliary colic. That's called cholecystitis, or inflammation and infection of the gallbladder. In a situation where the gallbladder squeezes, it pushes a stone into the neck of the gallbladder, that stone gets stuck there, it doesn't fall back, the gallbladder starts to get dilated, gets infected, and the pain doesn't go away. This is more urgent. So what patients will experience is the same kind of pain, more severe, more constant. It does not go away like it usually did. Usually there's nausea and vomiting. Rarely, sometimes there can be fever. These patients get pretty sick and end up coming to the emergency room. In that case, an ultrasound is done. Gallbladder shows that not only are there stones now, but there's infection there. And that's when I get called to do more of an urgent emergent surgery to remove the gallbladder.
And I'm sure waiting that long can create more complications.
That's correct. So if, a lot of times patients, when they present with the infection in their gallbladder, had previously been having symptoms of the pain coming and going, the more simple biliary colic like pain that goes ignored. When the infection starts to set in, yes, it's not as ideal because you will end up needing an emergency surgery, which is never as good as one that's planned out and done as an outpatient. But if it does progress even further, in some cases, the gallbladder can become gangrenous or dead. And that becomes a real problem in emergency. Patients get very, very sick and can develop sepsis, and it can actually be deadly. So we do encourage people, if they're having symptoms like this, see your primary care doctor, get the workup. Some people will confuse it for gastric acid or reflux or gastritis or something like that. But don't put it off, get your gallbladder checked because it could be stones.
So I have to have the surgery. What's the surgery like?
Yeah. So the surgery itself, if done, on an sometimes even an emergent basis, but as an outpatient basis, straightforward gallbladder surgery is usually laparoscopic. 4 small incisions usually takes 20 to 30 minutes for a more straightforward gallbladder. But, once it's more inflamed, more infected, if there's scar tissue bleeding, it could even take up to sometimes an hour and a half to 2 hours. And very rarely, sometimes I have to do it open and not laparoscopically. That's in the emergent situation. So another reason to, get this done earlier, more on an outpatient basis.
And what's the recoup time? When could I go back to work or back to life?
For straightforward laparoscopic surgery, typically you go home the same day after the surgery. You'll be down for a good 3 to 5 days, like any other operation or laparoscopic operation. But I've had patients that get back up and go back to work after 5 days, sometimes even 3 days if they really want to. But I always encourage them to rest, at least for a few days, take it easy for the week and go right back to what you were doing before. I still want you to remain active even immediately after surgery. So it does not have a big downtime at all.
I'm sure if it's more complicated, though, the longer the recoup time would be.
Yes, the more complicated gallbladders that require an open procedure, patients usually stay in the hospital for 3 to 5 days after surgery, and the recovery takes much longer, usually up to 2 weeks when open operation, all the way up to 5 to 6 weeks.
So if someone's having these problems and everything, I gather they should either go to their family practice, or I'm sure they can come straight to you if their insurance allows that.
Yeah, if it does, sure, absolutely. So if they come with me and they have the description of this right upper quadrant pain, or even epigastric pain, I am happy to do the workup for you. I could send you to get the ultrasound. You may even need, if that comes back negative, you may even need an EGD or a scope from the top to look into your stomach. And that's actually something that I do as well.
And if you're worried about being out of work or out or whatever, it would be better to do it before it gets bad.
That's correct. Absolutely. Anytime that there's a surgery that can be done as an outpatient, it's always going to be better, from a recovery standpoint. We know that you are in a position and healthy enough to undergo an operation. There's no missed cardiac issues or blood pressure problems that that we're having to deal with last minute like we would in an emergent situation. It's just always safer and better to do as an outpatient and get done sooner.
Yeah, I know you probably answered this question, but I'm going to ask it again. Are there certain foods to avoid after having the gallbladder removed or before that could help?
Yeah, so typically, well, after the gallbladder is removed, I don't like putting any diet restrictions on my patients, and it's not really necessary. However, there is a small percentage of patients that may experience after surgery, almost immediately after surgery, they may experience diarrhea for a week or two. That's only because the liver is trying to adjust for the loss of the gallbladder, because now it's taking over completely for the bile secretion. So for those patients, usually I'll say, hey, you may develop some diarrhea after surgery. If you don't, go ahead and eat whatever you want. But if you do, at that point, just go on a low-fat diet. Don't eat greasy foods. Don't eat fried foods, fatty foods. Very low-fat, bland diet until the diarrhea resolves. Once it resolves, they can go back to no diet restrictions, eating what they want. But more importantly, so there are situations, so before your surgery, when we know you have gallstones, we know it's been causing you problems, you have your surgery set up for, let's say 3 weeks from now, or, a month away before you have your surgery, there's ways to avoid that pain coming, or try to minimize the pain coming or having complications before your surgery comes. And that is by eating a low-fat diet, because we're trying not to trigger that gallbladder to squeeze during that period of time that you're waiting for your operation. Low-fat diet doesn't necessarily, prevent you from needing an operation. You're going to still have those stones. The stones will not go away. They will likely continue to give you problems down in the future, but at least we can try to minimize some of the episodes that you're having until your operation comes.
So it sounds like if you have gallstones starting and you get them, you might as well get it fixed if it's bothering you, so you can plan when you're going to be out versus ending up in an emergency room.
Exactly. So either you're going to determine when your gallbladder comes out, or your gallbladder is going to determine when your gallbladder comes out. And you want to be the one that determines that, not your gallbladder.
So I'm going to switch a subject on you real quick, because we hear about the gallbladders and we see them come in the ER and people are hurting really bad. Get it taken care of. But there's something else we've been seeing a lot of, and kind of making sure we recognize this as very important, is appendicitis. Can we talk about appendicitis and
Sure.
what it means and how we get there?
Yeah, so appendicitis, so you might hear about appendicitis most commonly happening in children. It's common in, young boys. But again, just like gallbladders, I've seen it in all demographics. I do appendix removals on all age groups. Like I said, children all the way up to 90-year-old people. Okay. So the appendix is essentially just a little appendage or extension of your colon. It's almost like a tiny little pinky finger that hangs off the side. And it's hollow as well, just like your intestines are. Well, sometimes that little appendage or appendix can get inflamed and infected. Okay. And the symptoms that people usually experience first is pain that kind of lingers around the belly button. It's a little vague. It sits around the belly button. You get nauseous. You don't want to eat anything. You may vomit. And then as the day progresses, that pain starts to more localize to the right lower quadrant of the abdomen. So it starts to move to the right lower quadrant. This isn't, the end all be all symptoms that you may have, because some people, their gallbladder's tucked behind their colon, and sometimes they'll have pain in their back even. So that's the most common presentation. But sometimes I've had patients complaining of back pain or lower abdominal pain or whatever, but usually around the belly button, and it goes to the right lower quadrant. If that happens, you need to come to the emergency room, because there's a good chance that you have appendicitis. In women, we also have to rule out things like ovarian abscesses, any ovarian or gynecologic issues, of course, but especially in men and women, right lower quadrant pain that progresses, does not get better, needs to be addressed, because it can be appendicitis.
So if we hang around and think it's going to go away, and it keeps getting worse, is there a chance that it could rupture?
Yes, absolutely. So one of the risks of having an untreated appendicitis is its progression to perforation or gangrene, and it can leave you with infection within the abdomen, can leave you with abscesses. You could become septic, and it's not something you want to sit on because absolutely you can get much sicker. You come to the ER, we get you on antibiotics right away, get you your CAT scan, get your diagnosis. We get it out before it leads to a perforation. There are studies, newer studies that show that we can treat some early appendicitis with antibiotics. I have done that, but I do that on a select group of patients, usually patients that are not great candidates for surgery, or somebody who absolutely doesn't want to undergo an operation. But typically, I don't recommend that as a first line because at the end of the day, if this thing gets infected again or it gets worse, or the antibiotics don't work, we don't want it to get to a point where you get very, very sick. So it's a simple operation. It's laparoscopic. It can take minutes, 15 to 30 minutes. Of course, if it's a very bad one, it might take longer, but for the most part, it's pretty straightforward laparoscopic surgery.
And I guess the recoup time and back to work is about the same as a
Yeah, I would
gallbladder.
say about the same as a gallbladder, unless you have a perforation. Perforated, I keep you in the hospital for 3 days for some IV antibiotics and then send you home with some antibiotics as well. That's just to make sure that you don't have any, residual infection in the area or in your bloodstream.
Good information to know. Is there anything else you'd like us to know? Because general surgeries do so much. And I'm amazed all the time. I understand y'all also deal with hemorrhoids
Yeah, I do. I do deal with hemorrhoids as well.
and
Hemorrhoids,
hernias.
yep, hernias. So general surgeons such as I do multiple different kinds of operations, anywhere from colon cancers, simple hernias, inguinal hernias, umbilical hernias, to hemorrhoids, thyroid, so skin, even little pimple popping cysts. So
Yes.
yeah, so I don't only see patients with gallbladder, so any general surgical issue I can take care of, and see you in the office for.
And
So
I also understand you do colon screenings.
I do. So I also do colonoscopies and EGDs. I can do your colonoscopy every 3, 5 to 10 years or whatever is indicated for you, and remove polyps or whatever we need to do with the colonoscopy.
Dr. Lubrano, it has been a pleasure having you today. You've given us a lot of good information. It's important that we take care of ourselves and do things before they become emergencies. These guys are great surgeons, but their lives are much easier if we do things before they become critical.
That's correct.
Thank you for joining us. Big thank you to our listeners for tuning in. Beginning now, set an intention and a relentless focus on living your life as the greatest person you can be in all situations. Please join us next week.
Thank you for joining us today on Oak Bend Medical Center Happy Hour podcast. We hope you enjoyed today's broadcast and invite you to email us at oakbendhappyhourpodcast@obmc.org with any questions or topics that you would like for us to cover. Remember, you can find us here each Friday at 5. Until next week, be mindful and stay healthy.